So I think we'll get started now. If that's okay with everyone. All right. Welcome, everyone. Welcome to the Family Center COVID Q&A Part 2. My name is Jackie Gruber, and I'm a white European settler of Jewish descent, and my pronouns are she, her, and hers. And before we begin, I would like to acknowledge that we are meeting virtually on the traditional lands of the Anishinaabe, Cree, Oji-Cree, Dene, and Dakota people that include Treaty Number 1, unceded lands, and the Métis homelands. We pay our respects to the First Nations, Métis, and Inuit ancestors and affirm our commitment to respectful relationships with one another and this land. Treaty 1, signed in 1871, took this territory from 7 local Anishinaabe First Nations in order to make the land available for settler use and ownership. We also want to acknowledge that our water is sourced from Shoal Lake 40 First Nation. Every time we acknowledge these truths, there's an opportunity to reflect on what we do and what we can do to make Manitoba a better place for everyone who lives here. So it's my pleasure today for us to be hosting the second dialogue, the second Q&A on COVID-19 with Ms. Raman Dhaliwal and with Dr. Jason Kindrachuk as well. What we do have at Rady Faculty of Health Sciences, we have a COVID-19 support working group, and things that we've heard from the community is wanting communication in terms of activities and what's happening to address COVID-19, but also having that communication in a different way. And so we had a great response to the first Q&A, and we thought we'd follow up with the second one. So I just want to remind people that this will be recorded and it will be placed on the Rady Faculty of Health Sciences COVID webpage as well after, so people can access this recording too. So it's my pleasure to introduce Ms. Raman Dhaliwal, Director of Administration and Operations, and Dr. Jason Kindrachuk, Assistant Professor, Department of Microbiology at the University of Manitoba and Canada Research Chair. Raman will present first and then be handing it over to Jason. If there are questions, please use the chat function to ask, and myself and Colleen from the Family Center will be monitoring these. So I'll pass it on to Raman.
Thanks very much, Jackie, and thanks very much to the Family Center for organizing this today for Dr. Kindrachuk and myself to present to Rady Faculty of Health Sciences. So I'm going to start with just a presentation of COVID-19 in Rady Faculty of Health Sciences, and then Dr. Kindrachuk will take us through variants of concern, vaccines, and COVID-19 in particular. So I always like to start the discussion by framing our current situation, both globally, provincially as well. And so as of yesterday, there are 121 million confirmed cases of COVID-19 across the world, and provincially, there's 32,903 confirmed cases. There have been 917 deaths within the province of Manitoba, and over 30,000 people have recovered from COVID-19. So as of yesterday, there were about 149 people in hospital with 10 people in ICU. Provincial test positivity is trending in the right direction at 4.4%, and Winnipeg test positivity is at 3.4%. And reports of variants of concern continue to be on the rise in the province of Manitoba. There's been 52 cases of the B117 strain and 12 of the B13351 strain. And just as a reminder that our current public health orders are expiring March 26, 2021. We'll be watching that closely at the University of Manitoba, as it could lead to further reopening within our campuses. So now to bring the conversation back to our local University of Manitoba context. Since the beginning of fall term, we've had 90 COVID-19 positive cases reported across all University of Manitoba campuses. So that includes the Fort Garry campus, the Bantein campus, as well as William Norrie. In Rady Faculty of Health Sciences in particular, there have been 50 cases, and the distribution is there for you to see. As you can see, they're more heavily weighted towards colleges of medicine and nursing, and the numbers with Rady being more than half of the cases across the entire university are not really surprising when considering the amount of in-person academic and research activity that we have in our campus. So earlier this week, there was a notice that went out around the entry point screening. So we will be discontinuing our entry point screening as of April 5th. So just by way of reminder, we started this entry point screening back on June 5th, 2020. So it's been a long time since we've had that in place. I'd like to give a big thank you to everyone that's been cooperative as we've done the entry point screening, both at the Bannatyne campus and Helen Glass at the Fort Garry campus. And also a big thank you to our screeners that have done a fantastic job in keeping everybody safe in our Rady Faculty of Health Sciences. So dental clinic screening will remain in place. As you know, this is a patient access entrance, and so patients are not necessarily familiar with our screening protocols. And so we'll keep that screening going for some time still. So as of April 5th, it's very important that you have swipe access to our campus. So you need to check that with your supervisor or instructor to ensure you're able to access both the Helen Glass building at Fort Garry as well as Bannatyne campus through the card readers. And so unlike what we have now, where at the Bannatyne campus, you can only enter through specific screening entrances. As of April 5th, you'll be able to swipe into any card access entry. And so that is a change, and that will provide more accessibility to our campus. So very important to make sure that you have access through your card access. And if you don't, please get that arranged before April 5th. So some just reminders of our procedure in general. So when we first reopened our campus back in June of 2020, we wanted everyone to complete the online shared health COVID-19 self-assessment tool prior to arriving. This is still in effect. You need to answer no to all those questions. Should you answer yes to any of those questions, you need to reach out to your supervisor or instructor for further information on what to do next. By swiping your card to enter the facility, you're acknowledging that you've done that questionnaire and you've answered no to all the questions. So we have given ourselves a little bit of leeway time to implement this in Rady Faculty of Health Sciences. So we have a couple of weeks still before this takes effect, because there are some logistical issues that we need to work through. So right now, if you're on campus for a research or academic activity, the session holder or your PI gives you your medical grade mask that's required in that setting. When you're here for access to your office only, you usually get that 3-ply disposable mask at the screening stations. So we need a little bit of time just to figure out how individuals that are accessing offices will get access to that 3-ply disposable mask, which we're working through right now. And we'll provide that information very shortly to Rady Faculty of Health Sciences. The other area that we needed to focus on was courier deliveries. And so, as you know, we were in complete lockdown in March and we managed the courier deliveries at that point. So we'll likely employ a similar strategy, trying to make it as easy as possible for everyone with your couriers. Another thing that we're working through right now is, as you know, the Bannatyne campus is connected to Health Sciences Center through tunnel access. They've kept that tunnel connection open for us because we've had the same kind of screening as them. They actually trained our screeners. And so with these changes, they are reviewing that access control and seeing if there needs to be any changes made. I don't foresee that there will be any, but we're in constant communication with them to figure out how that would work. Again, this wouldn't impact anyone that has access to both Health Sciences Center and the University Bannatyne campus. It would be only for those individuals where you only have access to the University of Manitoba Bannatyne campus. So again, working through those issues, and we'll provide feedback as soon as we have it. So in Rady Faculty of Health Sciences, we're always looking at our PPE strategy, and we are not experts in this area by any stretch of the imagination. So we usually rely very heavily on shared health and our public health experts, who are also members of our faculty. And so with the variants of concerns being reported, we did take a look at our masking strategies and the level of masks that we provide, and have made one key change in the area of clinical skills. So in those settings, participants are not able to physically distance, and they're in closed, smaller spaces for a longer period of time. And so in response to that, and in an effort to keep the university community safe, we will be implementing level 3 masks in that setting effective immediately. And so the session holders will be providing those participants with level 3 masks, in addition to the eye protection, which is mandatory. Should that not be available, that individual would not be able to participate in that session. All other PPE remains the same. So level 1 medical grade masks for any other academic activity which is on site, as well as level 1 medical grade masks in the research labs as well, in addition to face shields when there's more than one person in the lab. So last week, there was also a communication from the Vice Provost office that the university as a whole is looking at increasing activity on campus. So research can now ramp up activity within research labs up to 40% capacity. This does require approval from the Vice Dean Research. So our previous approval processes have not changed. That same approval is in place. They're also now looking at restarting human participant research and have articulated a process for approval around that. So that message came out through the VPRIO office, and so also was communicated through the provost email as well. And again, that PPE for the research labs remains in effect for now. So one area that we've come back to a few times during the pandemic as the COVID-19 situation evolves is electives, which occur out of province and also out of province placements. And so there are many criteria that went into assessing our strategy with respect to this as we move forward, such as the variants of concern being on the rise and the fact that there were reports in other provinces before they were in ours, the test positivity, and also vaccine rollout. And also looking at the public health restrictions related to travel in particular. And so currently the public health orders strongly recommend against non-essential travel and require 14-day self-isolation when traveling outside of Manitoba. So looking at all of those different criteria, we in Rady Faculty of Health Sciences have decided to pause incoming and outgoing external electives until June 30th, 2021. So we've extended it from March 31st to the end of June. We figured this would allow the programs to plan things more effectively and also provide feedback to the learners that this change is here. And we will revisit it closer to June to see what that strategy would be July onwards from there. There are also a handful of out-of-province placements in the College of Rehab Sciences, which we'll continue to review on a case-by-case basis as we have been. So the other major announcement that's come out through central administration is that in fall term, there will be more on-campus activity, but we are not returning to full on-campus activity similar to other universities. So universities in BC and Ontario have announced a full return back to campus in the fall. Our university is being a bit more measured in our approach, and the same kind of approval process will apply. Or any in-person activity that we in Rady Faculty of Health Sciences would like to have, we would have to do a submission to Central for approval. So some of the principles that we'll use around this is that sessions that have been running in person over the last academic year will likely be prioritized to run in person over this upcoming academic year. Those sessions were on site because they couldn't be delivered remotely. And we will have space constraints, also PPE constraints that we need to consider. And so those sessions will be given priority. We will ask all colleges and programs to submit additional sessions that they would like to have on site that are lower than that 20-person threshold that was announced through central admin. And large classes will likely continue to be conducted remotely. And of course, central approval is required for any of this. However, we will coordinate a Rady Faculty of Health Sciences submission as we have in previous terms. So more information on that will follow from my office in the next few days. At this time, we'll also be able to ask for some exams to be done in person. So there has been some challenges with conducting exams remotely that I'm aware of, specifically around the NBMEs. So there'll be some allowances to have in-person exams, which we will include in our submission. And all of this is really foreshadowed by the fact that we need to start having some more larger discussions in other areas. So having more academic activity on campus will result in the need for more faculty to return to campus as well. So we're going to start in Rady Faculty of Health Sciences having more focused discussions with key stakeholders, such as those in attendance here today, to start thinking about what that looks like and also the impacts as a result of it to things like IT, space, the fact that individuals have worked effectively from home and what our long-term strategy with respect to that looks like. And of course, there's also the ongoing discussion around vaccinations, around COVID-19 and whether they become mandatory for entry into health sciences training programs. So that's been an active discussion with your college deans, associate deans, and will continue to be discussed as the vaccine rolls out. So that concludes my presentation. And at this time, I'm going to hand it over to Dr. Jason Kindrachuk.
Great, thanks a lot, Raman. And first of all, I just want to say that it's a pleasure to be participating in this event today. Certainly, it's more nerve-wracking when you're presenting to kind of a local audience of your peers than it ever is when you're doing it more broadly to the public. So hopefully, I won't get too many angry emails at the end of this saying that I made mistakes or said anything wrong. But I really want to kind of focus on a few things, right? So a bit of an idea of what we're dealing with in regards to coronaviruses. But also specifically talking about where we are with variants and what we understand about transmission. Certainly, this has been a period of growth in the past 15 months for us to really kind of take a look back on what we truly understand about coronaviruses, and certainly how SARS-CoV-2 has actually changed, I think, our perspectives in many ways. So just kind of a short history. So Coronaviridae is the virus family. They're positive sense RNA viruses. They have very large genomes, but there are multiple subfamily members. And I think the important thing for us to kind of keep in mind is SARS-CoV-2 is obviously not the first coronavirus that emerged, nor was the original SARS coronavirus or MERS coronavirus. Prior to 2002, there were 4 circulating human coronaviruses that were largely seen as being cold-like viruses. There was more, often than not, kind of thought of as being an inconvenience. And certainly, the original SARS coronavirus changed that perspective in the early 2000s. But I think that we have constantly been battling with trying to get recognition for the true global threat that coronaviruses, seeing that play out. On the right-hand side of the slide, what I put out was basically just an overall phylogeny of what we had for SARS-CoV-2. So very early on, really within about 10 days of the original identification of SARS-CoV-2 from the original Chinese cohort that was identified in Wuhan, we were able to go through sequence information and characterize this as likely being a new novel bat coronavirus that had spilled over into humans. So there's certainly a lot of chatter in regards to where this virus came from. I think ultimately the majority of the scientific community agrees that this is something that has yet again spilled over from bats. Next slide, please. So the current state of knowledge in regards to SARS-CoV-2 transmission. And the figure on the right, I always like to put, a bit of, kind of a nice self-aggrandizing moment out for work that I've been involved in. But I think this is more a culmination of work that Dr. Mujsevic has been carrying out from St. Andrews in Scotland. Muj is a really amazing ID physician, has been doing a ton of work on SARS-CoV-2. And this is where our current state of knowledge is in regarding to the kind of the clinical course of illness for the virus. So we see this initial period of time, people get infected, and we look at a period of about 2 to 5 days prior to symptom onset, where the virus essentially is replicating in the background, which often happens with other viruses. But really the kind of corollary with SARS-CoV-2 is the fact that it is able to transmit during this period. And that puts us into a bit of a quandary, because we have people that are infected, don't know they're infected, likely don't know when they become symptomatic. At that point, they've already been spreading it out in the community, and that now leads to broader community transmission. Not that surprising to us, but maybe quite surprising to a lot of people is the fact that when we look at this kind of transition from mild illness to critical and severe illness, rather than seeing the virus kind of following that same linear trajectory where you would think, okay, more virus, person is getting more sick and getting more ill, we actually see somewhat of the opposite of that, that basically the virus kind of peaks out fairly early on in symptom onset, and actually is dropping off as disease is kind of progressing. And this is something certainly in my work with Ebola that we've seen in the past, where there is this kind of switch from basically being a viral mediated disease to now being an overactivation of the immune system that is driving that disease process. And that certainly much more complicated from a treatment perspective. And I say that as a virologist and not as a clinician. When we look back at this virus versus the original SARS coronavirus, certainly there are things that stand out with SARS-CoV-2 as far as why this virus has been more transmissible. For those that maybe don't remember, the original SARS coronavirus in 2002, we certainly saw transmission amongst healthcare workers and in healthcare settings. So people that were in close contact with patients that were highly infectious. But what we didn't tend to see was that broad community transmission that we are now seeing with this virus. And we think part of this is related back to how SARS coronavirus 2 interacts with our cells. It's kind of like, putting a key into the lock on your door. Over time, if that key is a little bit run down, maybe it doesn't fit as snugly into the lock anymore. And it takes a little bit of give to actually open up the door to get into your house. Well, the original SARS coronavirus was somewhat like that with the 2 receptor, in that it bound to it and it used this as being the antenna for which it would attach to our cells. But it wasn't necessarily a strong interaction. What we see with SARS-CoV-2 is that interaction is much more strong. It's basically a new key. It fits the lock much, much better. And the likelihood is that is what is helping with the uptake of infection. But there are a lot of unknowns that we're facing right now. Certainly, this idea of what the infectious dose is of the virus, I don't think we truly know. Certainly, we can go back and look at what are some of the estimates of the original SARS-CoV and what MERS coronavirus is, and kind of look at what our understanding is and say, okay, well, we think it fits somewhere in this middle range. So we think it's probably in the neighborhood of probably hundreds of infectious particles that a person needs to be exposed to get infected. But of course, there's a caveat to that, which is it's not just about the amount of virus you're exposed to. We certainly know that there are also a number of underlying biological components for the person that's being infected that also dictates how well they're infected and how disease progresses. Certainly, I think we're certainly at a much better understanding of the diversity of clinical presentation for the disease. But I think trying to understand what the underlying mechanisms of that differential disease course looks like. What is the difference between, I'm 44, so somebody that's my age that is infected but is asymptomatically infected or has mild disease versus somebody that ends up on mechanical ventilation. I think those are the answers that we still certainly need to address. And certainly, what are the factors that contribute to aerosol transmission? I don't think there's been probably any greater debate in virology in the past in regards to how viruses are transmitted, whether it's aerosol or droplets. And certainly, we've seen that with SARS-CoV-2. Where we certainly sit right now is that I think we're looking at a balance between these two. It likely is the pandemic being driven through droplets, and in some cases through aerosol touching your eyes is what's driving the pandemic. Certainly there were those fears at the start in early 2020. They likely contribute to some cases, but it's not what's driving that community transmission. So I think you're starting to see that that changeover in some of the guidance that's being recommended, where we talk about enclosed spaces and this idea of trying to reduce that overall time of being in one particular place or enclosed setting with reduced ventilation with larger groups of people. Certainly, we know that there are more infections that occur in those settings. Certainly, prolonged exposure. So the longer that you are around somebody is likely going to dictate as well whether or not you're infected. Again, it's not just about that infectious dose at that one static moment in time, but also about the accumulation of virus that you're being exposed to. So maybe somebody is emitting a low amount of virus, but if you're exposed for a long period of time, that becomes additive during that time period. And certainly ventilation and air handling. I think that there has been certainly a number of panels that I've sat on the last year where we've discussed this very broadly and how we can better address this from I think a public safety standpoint. Next slide, please. So from the idea of droplets and aerosols, listen, I don't think we are going to be able to come up with some grand answer as far as, okay, this is X, the X percentage of cases that are being driven by droplets, and this is the Y percentage that's being driven by aerosols. Certainly trying to distinguish these two is not necessarily easy. We can do some of that through some of the epidemiology that is being done in case investigations, but trying to do this in the lab and replicate these experiences is very difficult. So when we look at the top, this was a study that was done through the University of Nebraska, looking at basically trying to capture infectious particles in hospital rooms from patients that have been infected with SARS coronavirus 2. They basically able to recover that RNA, that genome from the virus. The problem is that viral genome does not necessarily tell you that there is absolutely infectious virus there. Certainly, we've seen that very often in the past, that you can have remnants of genome without actually having infectious virus. So the recovery on infectious virus has always been very limited, but that's also based on the actual limitations of the sampling methods. So I think we're still somewhat in a bit of gray area. There have been some really phenomenal studies looking at animal models of infection. We do a lot of work here at Vito, where I am until June 1st, doing work on COVID-19. In the ferret model, one of the things that's great about ferrets is you can look at disease transmission through coughing and sneezing and contact. Well, what they've been able to show is that if you have an infected ferret on a bottom cage and you have that cage linked to another cage just by tubing, so there's no other airflow that is connecting those two cages, and that basically that tubing goes for about 1 meter in distance. What you can see is that basically that infected ferret will transmit virus to that naive ferret that is basically a distance of 1 meter away. And that tubing goes through a number of bends and a number of 90-degree turns, which would suggest that this idea of just droplets alone being able to transmit and cause infection is somewhat limited. It doesn't tell us specifically that aerosol is the only way, but it certainly tells us that aerosols are contributing to some extent. Next slide, please. So where do we sit today? Certainly the last few months have been very busy when we think about where we have been from really early December onwards. We've heard about the variants of concern, and certainly I think we want to appreciate the fact that the variants of concern are a true concern for us. The figure on the left is basically the spike protein. So the protein that sits on the virion of the receptor on the outside of the virus itself, and that's what dictates how the virus interacts with our cells. Well, what we've seen over time is that there are mutations that occur within this receptor. So as viruses transmit, they tend to mutate. Yes, coronaviruses mutate to a lower degree than what other RNA viruses, but still mutate. And certainly what we've seen, and those of you that have followed the news, is we've seen basically the movement of this virus from humans into animals, and sometimes there are cases now of gorillas being infected, and of course mink, which are the only species right now where we see not only are humans able to transmit to the animal, but the animal is able to transmit back to the human. Well, through all of these events, what we've seen is that there are mutations that occur. And of course, just transmitting from human to human, we also see mutations. Well, where we're sitting right now is getting a better idea of what those mutations look like. Certainly, we see mutations in very specific regions of the protein, and these are the things that tend to guide either how well the virus binds to our cells or how well antibodies are able to potentially bind to the virus and stop it from infecting our cells. Next slide, please. So we're really right now talking about 3 primary variants of concern. There have been a couple more that have been added through the US convention as of yesterday that are unique US variants. But right now we're looking at B117, which first emerged in the UK, B1351, which first emerged in South Africa, was first identified in South Africa, and P1, which was first identified in Brazil. Now, what we have to keep in mind is that all 3 of these variants emerged independently of one another. Okay, so it wasn't like person A moved from the UK to South Africa to Brazil and spread the virus in 3 different places. What we saw was that there was some sort of convergent evolution that led to basically these 3 variants are actually carrying many of the same mutations. And that's important for us because what it starts to tell us is a little bit of information about what is driving the emergence of these variants. Certainly, I think that the kind of the going theory right now is the likelihood there are people that are immunocompromised that carry the virus for a longer period of time. And that likely also helps with this longer evolution and mutation period for the virus. So what we see are basically certain mutations that are popping up. And these are mutations that are related, again, to how well the virus attaches to our cells, as well as how antibodies or how well antibodies are able to bind to the virus. And this is concerning for us because what it tells us is that the virus has a blueprint in some respects for how to do things and how to basically get around some of the the facets of our immune systems. I think what's important for us to keep in mind is that this virus has really only been in humans probably for a period of 15 months, give or take a few months. So it's just starting to stretch its legs as far as what it does. It's learning how to transmit from human to human. So these mutations are things that we will continue to see over time. We don't necessarily know what the implications will be, but the virus is starting to tell us where there are specific focal points that we need to be aware of. So certainly these three variants present I think, true concern for us right now, but it also tells us that we can start to watch for other variants that house similar mutations and be able to identify those as quickly as possible. Next slide, please. And I think one of the important things for us to keep in mind is that when we think about these variants of concern, we have to also appreciate that these aren't variants that have suddenly gained superpowers. They don't have the ability to suddenly move through N95 masks from what we've seen. They don't have the ability to move through walls or be able to completely counteract all the vaccines that are currently available. There are caveats to all of those. But what we know, or what we've seen at least presented, infection prevention control experts, is that our current infection prevention control measures largely will still enable us to defend the virus. It just, this idea of the fit of the mask, how we're wearing it, how we are using the mask, when we're using it. All of those things become much more strategically important than they ever have in the past. Maybe we had a little bit more leeway when we had the prior circulating strains in our communities. Now with the variants, because of the increased transmissibility, certainly in B117, and certainly with some of the concerns we've seen in regards to increased risk of severe disease with B117 and P1 and B1351, we need to be much more focused on the things we're doing from an infection prevention control standpoint. So I think it's certainly a concerning period in time. We're in a bit of a race to try and get vaccines disseminated as quickly as possible. Just right before I started speaking, the US announced that they are going to supply Canada with 1.5 million doses of AstraZeneca. So again, it's another potential victory for us to be able to get more people vaccinated. But we have to appreciate that in that time period, while we're waiting for those vaccines to roll out, it's still incumbent upon us to make good decisions to try and reduce transmission as well as possible. And I think next slide is the open question slide, I believe. Perfect. So thank you.
Wonderful. Thank you so much, Ms. Raman Dhaliwal and Dr. Kindrachuk. So we just would like to open this now to questions. So please feel free to put your question in chat and we will address it. And maybe, oh, sorry, is someone else speaking?
It's Colleen.
Okay, great, Colleen.
A few questions came in ahead of time.
Perfect.
Did Dr. Kindrachuk include that in your presentation?
Those to some extent.
Okay, do you want me to ask you the questions that were written?
Yeah, that would be great.
Okay, so what is the reinfection rate with the same COVID strain or variant?
Yeah, it's a great question. So there's a study that came out from Denmark yesterday that was actually looking specifically at this. So it was the first population-wide study where they've actually looked at reinfection rate across everybody that have recorded infections. Previous infection was quite low, so around 0.65%, which is exceedingly low when we think about this, this idea of whether or not people can get reinfected. And it certainly harkens back to this idea that when people are initially infected, there's some sort of natural immunity that is generated. We don't necessarily know how long that lasts for or the extent to which that provides long-term protection. But it at least looks like it defends against reinfection. And that's important for us. I think it gives us kind of a moment of pause to say, okay, we hopefully will not see new subsequent waves of infection that completely counteract everything or everybody that has been infected previously, so that we're basically back at square one. Now, the caveat to that is when we look at Brazil, certainly in Manos, Brazil, we saw in early 2020 and mid 2020, fairly high transmission of SARS-CoV-2. Seroprevalence rates, so the amount of people that were showing up with antibodies against the virus, were quite high, in some cases getting up close to that kind of herd immunity level of between 60 and 70%. But what we've seen now, and certainly anybody that's back facing a pretty horrible new wave of COVID infection. So there is this question of whether or not there are reinfections and reinfections with some of the new variants that are emerging. I don't think we quite know the complete answer to that. I think we certainly see that in naive populations and in areas where you can't get adequate, potentially adequate healthcare service, or you don't get adequate rollout of vaccines, that we just see infections at a very high rate. So I think when we think about this idea of vaccination, the vaccines so far seem to be doing quite well. And I would go back to this idea of what we're seeing in the UK, where as the vaccines have been rolled out, even though B117 has taken over the circulating strain there fairly quickly, we haven't seen a drop-off in the ability to control virus transmission. It has continued to look very, very good as vaccines have rolled out.
Thank you. Infection/infectiousness of immunized people who were documented to have protective antibody levels after immunization.
Yeah, another great question. So, this whole kind of corollary of vaccination of, okay, you can protect from severe disease, but what does that mean in regards to your ability to be protected from being infected and then still transmit? Certainly, as a scientific community, I think we've been very cautious in how we've spoken about the vaccines as they've rolled through clinical trials and as they've been approved in our messaging. And part of that is because I don't think we want to give any false representation of what the vaccines can and cannot do. We certainly don't know how well all the vaccines are able to protect against somebody being infected, even if it's asymptomatically, and then transmitting. But the real world data that we're seeing, certainly from Israel and certainly from the UK and from ongoing studies elsewhere, suggest that not only are we able to see good protection from severe disease, really with all the vaccines that have been licensed, but also decreased transmission. And I think that's really important for us. And again, I would harken back to this UK data where we look at really 10 million vaccine doses that have been administered for both AstraZeneca as well as for Pfizer. And what we see is that we're seeing rampant decreases in transmission rates, which suggests that the vaccines are truly working at decreasing the release of infectious virus from those people that have been vaccinated.
Okay, the next question in this series is, are studies being planned to investigate waning antibody levels and risk of reinfection need boosters?
Yeah, they are all ongoing. Listen, Dr. Florian Kramer down at Mount Sinai, I think has really been probably the global leader in doing this work and in really kind of taking charge of this. He's been looking at cohorts of patients for a long period of time and has been able to demonstrate that even people that were naturally infected have carried antibodies for up to 8 months. And that being said, that 8-month period is because that's the limitation or the furthest time point that they have for those patients during recovery. So it likely extends far beyond that. So I think we're getting a better picture of that. And I think there are concerns always about waning immunity, but that's why there's this idea of trying to make sure that even people that have been infected in the past still get vaccinated, so we can get basically that constant amount of antigenic material that's delivered to a patient, and they will hopefully have sustained immunity.
Okay, will we require annual boosters as part of the health regime, much as is recommended for the regular flu?
Yeah, it's a great question. Dr. Raywat Diondan had commented on this earlier today. And it basically said, listen, I know people aren't going to be happy, but I think we're probably going to need to go this direction. I'm not there yet. I think that there certainly is a case to be made that with the variants that we see emerging right now, that they're to match some of the variants of concern. But I think we're also accruing data right now, real time, at the overall, effectiveness of the vaccines in the real world against these variants of concern. And I think the data so far has looked fairly good. B1351 out of South Africa has been a little bit more questionable in regards to efficacy. But certainly we haven't seen the broad spread of that virus like we have B117. So to me, it may be something that we need to go to, but I think our biggest concern right now is getting transmission curbed, not only here in Canada and across North America and Europe, but also across low and middle income countries. If we want to control what's taken on us, we need to get everybody across the globe immune so that we can try and get this controlled as quickly as possible.
Okay, thank you. Are there significant differences to those over 65 in the available brands? AstraZeneca is not recommended in Europe, but now okay in Canada. How can safety concerns vary so widely from country to country?
Yeah, I think part of the reason why safety concerns can vary so widely is because of the time period in which we developed these vaccines. So, I will always kind of take a step back and say, listen, historically, when we look at the achievement that we made, and I say this as part of the global research community, but certainly the achievement that's been made by the men and women that have developed these vaccines, we've never, ever had this level of achievement in this past period of time. So certainly from that aspect, I think that we've done amazingly well. The overall clinical trials that were run on all the different vaccine candidates met the same criteria that would have been required outside of COVID that normally took a lot longer of a period of time. But of course, there are ongoing, investigations into novel disorders that may present, and trying to identify whether or not there is not necessarily just correlation, but if there's causation between these. Certainly with blood clots right now, there's been this question of, is there potential causation between the vaccine and some of the different clotting issues that have been reported? That's been an issue for us. And I think there's the aspect of saying, when we look at the overall toll of the disease, what is that as compared to some of the potential concerns have been highlighted? Is this truly above background for what you would normally see in a population just on any given day in regards to things like blood clots? And I think some of our European partners are trying to address that very quickly. I'm not a physician, so I look to those folks to try and make the recommendations they see fit. I'm comfortable with right now where we are with AstraZeneca. I think that we need to get people immunized. It seems to be a very good vaccine. The data, certainly in regards to people over 65, was really somewhat encumbered by the fact that when we go back to the phase 3 trials, the AstraZeneca just did not have enough people in that age bracket to meet significance within the trial. So it's not because it was never developed to go in a high age groups. It was just that they could not get enough people enrolled to meet statistical significance. Certainly what we're seeing now in the UK, again, with the broad distribution of AstraZeneca, is that the protection in folks that age 5 has been amazingly good. And I think that gives us kind of a moment of pause to say that we're seeing real world data. And as that real world data comes, we may have to change some of our viewpoints. Certainly, I appreciate where Canada has stood on this. Where we now are seeing the recommendations for people above 65. And I think you'll see many other nations that will follow that very soon.
And the last pre-submitted question is, what is the infectious dose for SARS coronavirus 2, and what would constitute ideal conditions for transmission?
Yeah, so the infectious dose, like I said, I don't think we fully know yet, right? And part of that is because it's not just about the virus, it's also about the situation, it's also about the time period in which we are exposed to the virus. Certainly the ideal conditions are you're in an enclosed setting, you have low ventilation, and you have somebody that's releasing a constant amount of virus. So as you're basically inhaling that over an extended period of time, that infectious dose is increasing, right? It's not just, again, about that first breath or that first inhalation of virus that you're taking. It's going to be that overall exposure for a long period of time. And certainly when we look at some of these super spreader events that have been related to broad dissemination of the virus in our communities, that has been a good indication of why, to me, that this is the primary concern for us.
Okay, we've had one question from the group. When can we expect to resume to normal activities? And is there a metric we are closely monitoring?
Yeah, I kind of almost get to a point where I don't remember what normal looks like anymore. When will we be back into 2019? It's a good question, right? I mean, certainly to some extent, I don't know as if we will go back to exactly what 2019 looked like. I think that there will be, some aspect where the virus is still transmitting in certain areas of the world. So for a long period of time, we're going to certainly have, I think ebbs and flows in regards to potential transmission events and certainly, being inundated in social media and over the media from stories of new cases that have shown up. Now, that being said, I think that the metric for us is really this idea of community transmission, right? So there's a metric in regards to herd immunity of trying to get to 60 to 70% of people immunized across our population to really get that kind of long-term protection, in particular within those high-risk groups. But I think the bigger question to me is how quickly can we get transmission down to as close to zero as possible? So think about this idea of like the current R values in different communities. We need to get that as low as possible and have that sustained. So for Manitoba, getting back to where we were last summer, certainly when I left Manitoba to become the Saskatchewan for the year, we had what it was like 13 days of zero cases. That's the position that I think we need to get back to before we really get back to that comfortability again, but also not just in our community, but certainly across Canada and then across broader communities across the globe as well.
Another question. Okay,
sorry.
ahead.
I have a question for Raman. Okay, I have a question for Raman. Has any air circulation testing been done in Rady?
So in the early days of the pandemic and the shutdown, physical plants certainly did air circulation studies and enhanced the ventilation where they were able to. In College of Dentistry, we bought a ton of air purifiers due to the fact that they do a lot of aerosol generating procedures. And we have requested physical plant to come back and look at areas where we do have a lot of in-person activities, such as our research labs and our CLSP, to see if anything further could be done. And the university as a whole is also looking at portable air purifiers and the science around that and whether or not it's effective. So that's the work that's been done to date.
For Dr. Kindrachuk, did the initial efficacy data for Pfizer and Moderna vaccines skew higher due to the absence of variants in the first trials?
Yeah, what a great question, right? So when we look at different vaccines, this has been one of the problems that we've had with trying to say, how do vaccines look against one another? You can't necessarily directly compare, say, Johnson & Johnson to AstraZeneca to Pfizer and Moderna, because really the periods in which those were tested, as well as the regions in which they were tested, transmission and current circulating strains were very different. It might have skewed things to some extent, but I think at the same time, certainly when we look back at not trying to keep bringing up the Pfizer data from the UK, but when we look at this data of 10 million people that have been vaccinated and where we know the UK was heading in early mid-December with B117 so quickly overtaking circulating strains, I think the data has actually held up really well. We haven't seen a lot of people that have been been immunized with either Pfizer or Moderna in real world settings that have ended up with symptomatic or have ended up with severe disease. I think the data has held very well. I think that the difference is that when we look at something like AstraZeneca, the AstraZeneca vaccine, I think was actually somewhat dismissed because of the low or the lower efficacy that had been reported, and people kind of looked at that as being a kind of a second tier vaccine. Well, in fact, the real world data I think is highly suggestive that in fact it works very, very well.
Okay. Any other questions for Dr. Kindrachuk or for Raman? No? Okay. Well, I think we're good. Thank you very much, Dr. Kindrachuk, and thank you very much, Raman, for participating in the event today.